So now we are recording. So thank you. Welcome, everyone. My name is Dr. Anthony Rivas. I'm a professor here at Sac State, and I'm also a licensed marriage and family therapist, a licensed addiction counselor in the state of Colorado. Colorado, we have a clinical licensure for addiction counseling, which requires a mental health degree, training in co-occurring, and it sits in parity with the LPC, Licensed Professional Counselor, which in California is called LPCC. I'm also a master addiction counselor, and I hold the U.S. Department of Transportation Substance Abuse Professional Credential also, where I work with individuals in safety-sensitive positions, FAA flight crews, railroad, oil and pipeline workers, any sort of substance use. And I see some head shaking. You guys know what a SAP is, a substance abuse professional. So that is my, I've worked both in academia and private practice. I've worked with court mandated offenders. I hate that term offenders, but that's the nomenclature back then. And so really working on destigmatizing to, instead of calling, individuals by disease or an offender, we really want to work toward, we always treat individuals and patients. So I'm going to hop in, and Adriana is going to monitor the chat for questions. I'm just going to bring up a PowerPoint, and I don't want to, like I said, do death by PowerPoint, but it just keeps me in on task. So social class bias. So we're going to go through some definitions, and we're going to talk about intergenerational poverty. We're going to talk about wealth and privilege. We're going to talk about our implications and structures for support that we can do, and then hopefully some resources. And so I would like this to be conversational. So if there is something that's coming up or something that hits home in your particular field, your agency, your community, please, share it. If we're in real life, we would be having a conversation during this, and I would like to keep that. So one of the things we want to do is define dual diagnosis, right? Dual diagnoses are co-occurring disorders, and as we heard earlier, some facilities, some agencies, Medi-Cal still treats substance use disorders and mental health concerns in a separate silo. Best practices via NADAC, NIDA indicate that co-occurring disorders or dual diagnosis must be treated together. So a substance use disorder, a mood disorder, treat together for best treatment outcomes. And when we treat them in silo, that's when we start seeing disconnects. So dual diagnosis, and for the individuals who do work in the field, it's the most inarticulate way to say this, but certain diagnoses and certain substances go together like peanut butter and jelly. And you probably see it more anecdotally in your space, where more patients are presenting with this diagnosis that also have this substance use disorder. And so examples, and all of you all are familiar with the mental health examples, but with substance use disorder, it can be polysubstance abuse, it can be illicit drugs, it can be instrumental drugs that individuals are using to the point of dependence. And so we need to really assess and understand what's going on with our clients and our patients. Some quick stats. 50 to 75% of all clients who receive treatment for a substance use disorder also have roughly, or 50 to 75% roughly, also have another diagnosable mental health concern. Psychiatric clients with a mental health disorder, 20 to 50% of them, and that's a huge range, also have or have had a substance use disorder at some point. And we do see individuals with mental health disorders medicating with substances. And we also see individuals with substance use disorders then eliciting underlying biological trigger for psychological disorder. And so what we want to do is really assess the genesis, and we need to treat both and to treat the person. Well, let's hop into social class. And I was looking through some stats today, and California has the highest poverty rate in the United States. And that's roughly at 18.2%. The only other states that have the next highest poverty rate to California, to our particular state, are Louisiana, Mississippi, and Florida. And they come in close, around 16%. Now, those numbers fluctuate. With pandemic, we know that the poverty rate has increased in multiple areas in the United States, but this is generally the national average. And California hovers between 13 to 18%, and as the states I said, but the number I kept hitting upon was the 18%. And that's selling it for our conversation today, because social class is an expression of who we are. It's an identity. It's where we come from. It's how we carry ourselves. It's how we speak. Everything that we do carries the air of our social class with us. There are undeniable, it's an undeniable reality, and we have implicit, overt rules of behavior within society, within our strata, and when we're working with individuals from other stratas. And I want you, as we're talking about this, to think about your own your own preconceived notions of different social classes, of patients that you've seen. When you drive down the street and you see somebody walking down the sidewalk, what preconceived notions do you have? And I'm going to put it out there. If you have a pulse and you're a human being, you have biases. Social class is one of them. As I said earlier, it's an inherent part of our being. There are ramifications for acting a certain way within or without your social class. And it's also one of the least discussed issues, but a very significant issue in American culture and American lives. When we think about, and I'll make a bold statement, in the United States, we commodify people. We commodify individuals. There's a movie on Amazon, and John Cusack was a scientist, and he kept asking people, what did you do to earn your place in this crowded world today? And it's a horrible saying, but we do that to patients, we do that to ourselves, and that impacts how we treat individuals. So there's the manifestation of classism within the individual. We look at it as internalized, upward, downward, lateral. And internalized is how we feel about ourselves, right? Negative connotations, any thoughts, emotional experiences, right? Related to our failure to maintain one's social standing. So I know during this time in our society, there's a fear. There's a fear of losing one's job, of dropping down a social class, right? There is this idea of keeping up with the Joneses that we have in the United States, where we keep this idea that we have to purchase things outside of our purview in order to maintain this idea of a middle class lifestyle. Upper classism, thoughts or feelings directed to folks above us financially, and we see them as uppity, snobby, bougie. Oftentimes we also ascribe very positive traits to them. Well, they must know something I don't know to obtain that. Jeff Bezos, a trillionaire, must know something I don't know. And so therefore they're inherently better. I'm not picking on Bezos. It's being recorded. Don't sue me, Jeff Bezos. Downward classism is the inherent or the feelings directed toward those who are in a lower SES. Remember when I asked you about your biases, lazy, unworthy, trashy. Think of all the names that society has used. And then there's lateral classism, the ones that keep us at a homeostasis, and we look around the people like us, the keeping up with the Joneses, maintaining our status, What car does my neighbor have? Is my car too old? All of those are manifestations, and we go through them daily. Think about the ads that you see on TV if you still watch commercials. Think of the ads in magazines. Think of the ads on the internet. What part of this are you being bombarded with? And I'm being heavy-handed with this because this directly translates into what we see and how we see our clients when they come in to seek treatment from us. The sense of identity, and I'm going to talk a little bit about something called over-precision. Over-precision is the idea that without having founded knowledge or without empirical evidence to back me up, based upon my life of privilege or my position of privilege, I assert that my ideas are right in the total absence of evidence to support it. And I'm going to go back a slide. When we look up, goes back to the Bezos comment I had. Well, they must know something that I don't know to be there. And when this group looks down, it is they don't know something I know, so I deserve to be here. This when we look at individuals from a lower SES, higher SES individuals have the tendency to feel that they have more power and deserve more power, whereas our low SES peers feel they have less power and oftentimes internalize they are deserving so of having less or deserving less power. Higher SES peers have a tendency to score higher on self-esteem and narcissism scale. I'm not saying everybody, and I'm not bashing anybody from a high SES. These are just some traits. Demonstrate over precision, what I talked about, and where their lower SES peers have a tendency to have the counter. Any questions or thoughts on that? Anything coming up for you as a practitioner, as a student, as a community member about that? Okay. That takes us into intergenerational poverty. Poverty, and this comes into identifying our own biases. Okay, I want you to think about that. Intergenerational poverty is oftentimes in our society looked at as a moral failing of the family system. Yet we do know that communities of color are systemically disenfranchised via criminal justice system, via access to care, foods, and we see food deserts, and we see banking deserts. We see the inability to obtain employment and obtain access to higher education. One of my areas of research is first-generation college students. 30% of low SES first-gen college high school graduates obtain admissions to post-secondary education. Of that 30%, only 15% persist to four-year graduation. That's abysmal. That ties into this intergenerational poverty and the academic failure. We do see poverty increases substance use. We see when we're saying antisocial, we're not talking about sociopathic or antisocial personality disorder. We're talking about a pro-social, antisocial. So we see in poverty that there is not pro-social behavior that the dominant culture deems. We see more incidences of depression, pregnancy, and this lends itself to keeping individuals in the generational poverty cycle. And one of the things in a previous session was talking about connecting all the community from K-12 up in this helps ameliorate this with access. Don't have to deal with neurological impulses. So some psychological impulses are implications of poverty. We see higher A scores, trauma response, substance use, as said, antisocial. So talk about, actually, sorry, I'm kind of jumping ahead. So with ACE score, right? What is an ACE score? I'm gonna lend it to you guys. I'm gonna throw it back to y'all. What's an ACE score? Stop sharing. Unmute. What's the ACE score? We're gonna go Socratic now.
So for me, I'm the nurse practitioner. We give all our patients something to fill out that tells us they're high risk, and that's what the ACE score usually is.
Okay.
It stands for adverse childhood experiences. So it's the adverse experiences that happened to you during childhood.
Yeah. The Kaiser Family Foundation did a longitudinal study. I believe the sample population was over 18,000 individuals. And they discovered, and I'm sharing it here, that individuals with 4 or more of these markers had more prevalence of psychological distress, trauma, substance use disorders, and health disorders, hypertension, cardiovascular disease, obesity, diabetes can be associated with this. And these are some of the questions, and this is readily accessible, and I can also send it to you if you like, and as most of you all probably have access to this. We're looking at what's occurring with this child prior to their 18th birthday, this individual. And oftentimes we neglect to understand that human beings are exposed to trauma through a myriad of ways, okay? Does trauma have to be war? Does trauma have to be robbery? Does trauma have to be rape? No. It can be an automobile accident. It can be watching a parent overdose. It could be watching a parent have a seizure. And it can be, I'm going to throw this out there, lockdown drills. It can manifest in a myriad of ways that we oftentimes don't think about. And our school counselors, this is something we have a discussion with, is really, assessing for that, and for the pediatricians, nurse practitioners, assessing for ACE very early on when interacting with children, and also not neglecting it if you're working with individuals who are older than 18 to look at what their trauma history is like. Mm-hmm. That makes the difference, because that gives us a picture of where the mental health concerns come from, or the substance use disorders can come from. I'm going to ask you to do something, and I want you to do this without censoring yourself. Look at these pictures, and what comes to your mind. You don't have to share. Right now,
it's still showing the ACE questionnaire.
Oh, no, I apologize. Good. So I'm going to show you a slide. You don't have to answer out loud, but I want you to think of what comes up for you when you look at these pictures. Let's give it a second. Any thoughts? Anybody would feel like sharing? I'll ask some questions. Think to yourself, okay? Are these people highly educated? Are they healthy? Are they in charge of their own destinies? Are they contributing to society? That's where our biases start to come up. And I want you to think about that, because each one of these individuals is a valued member of society. Each one of these individuals is worthy of quality care, access to care, and equity within that care. And that the underlying first is what can cause that disconnect. What do you think? What is your first thought when you see this group? Do these folks, are they healthy? Do they fundamentally have control of their future? What's different between them and the previous group?
There's a comment in the chat that says stage. Someone said yes, class.
Okay, yeah. These folks, staged, I like that because these folks get to pose for their pictures, right? And these folks, they don't get to pose for their pictures. Just that one thing of stage, who has control? Even though the photographer's, between the person on the other side of the lens, who has control between these two groups? These folks have control. The previous folks don't. Now this group. Any thoughts?
There's a comment saying higher importance, value.
Higher importance, valued, right?
Another one says power. Another comment, Photoshop.
Power Photoshop, yeah. Well, the more power you have, the better Photoshop you get, right? Life is always nicer in Photoshop, right? The
Another
Untouchables.
comment says, yeah, the Untouchables.
Okay.
Ironically, white passing, influencing, and upper class.
Yeah. And so that goes with that classism, the upper, lower, lateral, is we ascribe certain behaviors and certain identities. And one of the things that I noticed, and I'll kind of just stop share really quick here, is when I'm working with students and I'm training students, one of the hard parts is talking to them about treating all patients equally, because oftentimes you'll have individuals come in, obviously of a higher SES to them, and students will, and new interns, license eligible interns, oftentimes, and I'll even dare to say folks that are licensed, defer the expertise to the client who is at a perceived higher socioeconomic status than them, and will neglect, and there's a whole body of literature, and we can see that through the opioid crisis of healthcare providers negating pain reports from members of our BIPOC community. And so we do that with social class as well, where we will oftentimes negate their lived experience, their life experience, and assert certain behaviors. We're not going to play this game now, but I do want you to write that down. And this game is called Spent. And basically, it takes you 30 days to get through. You have 30 days to go through a budget based upon some of your answers. And it sees how long you can live on a certain budget. It's kind of an interesting thing for our biases, because oftentimes we come from a very moralistic standpoint when we are immoral, and the moral standpoint really influences our legislation and our legal system when it comes to substance use disorders. And one of the things with a moral framework is that if you have a substance use disorder, it is your fault. And so therefore you are the problem and I have no obligation to treat you. When our overarching legal system looks like that and our legislation and our laws look like that, it's not a far jump to now put that frame of reference onto our clients. Any questions or thoughts? Okay,
There was one more comment that was missed. It just said racial and mostly white people, I think in response to the picture.
Okay, so we're gonna check your biases really quick. Okay, y'all ready for that? Kind of, maybe not. Name the first population that comes to mind when you hear the prompt. Cocaine, crack, methamphetamine. Just sit with that for a minute. Think of what I want you to imagine what that person looks like. Anybody feeling brave enough to break those three down, what the person looks like sitting in front of you? They come in and they tell you, I use cocaine. They come in and say, I use crack. They come in and say, I use methamphetamine. Okay, heroin, crocodile, marijuana, prescription opioids, inhalants, benzos. What are some thoughts you have on that?
There's a comment that says MDMA, and there's a comment that said, what is crocodile?
Crocodile is a synthetic opioid popular in Eastern Europe, primarily the former Soviet Union, Russia, and it is very similar. It's made very similar to methamphetamine with, i.e., all the nasty chemicals, and it is a synthetic opioid that is injected, and it causes severe necrosis, and I believe the average life expectancy of individual who uses crocodile is roughly about a year from start to finish. The reason I put it on there is because we do live in a global society, and humans have a knack for trying to escape pain. And I remember reading one account of it popping up in New York. And so it is something to watch out for as well. So that's what crocodile. You can Google image if you have a strong urge to do so. There are some fabricated imagery. I would definitely, NIDA has some images of crocodile. Individuals use crocodile and definitions on it. National Institutes of Drug Abuse through the National Institutes of Health. Other thoughts?
There's a comment that says, is it the same as spice?
No, spice is going to be a synthetic. Generally, spice is synthetic marijuana leaning. So crocodile is separate of spice.
There's another comment that says, I have had to overcome many biases and am still shocked when faced with a situation like this. It is a stark reminder that I have a long ways to go. I'll be honest, crocodile equals S in my.
And that's the point of this chat, and I don't want to. It's not to shame. It's to get the conversation rolling of what are the barriers to care, because one of the things, and I can tell you this from Colorado, and I'm not sure what the waiting list is here. I came from Colorado right as we locked down. I moved from Colorado, and a waiting list for a Medicaid psychiatrist for a med eval was 6 months in Colorado Springs, about the city the size of Sacramento. 6 months. Private pay, you get in right away. Third-party reimbursement, Blue Cross Blue Shield, get in right away. And so what does that tell you where we place value on in our patients? And I know there's barriers, obviously, with how Medicaid, Medi-Cal pay and how they bill. But 6 months for somebody trying to seek treatment is a burden and is a barrier that most people will not wait for. And so it's not easier to continue using if you are faced with the ability to seek help or not seek help, and there's barriers in place. You're going to keep doing what you're doing because it's working. It's taking away the pain. I'd like to leave this little quote up there from you. And as you read it, I want you to think about the DEA was started in the Nixon administration. The DEA runs a schedule of drugs. And also the Nixon administration, funny sidebar, made Elvis Presley a honorary DEA agent. And if you know Elvis Presley's history, it was kind of an interesting background. So we do know that bias not only negatively affects access to care, it negatively affects legislation. And I'm going to go back to, if we don't view people with substance use disorder as needing or needing access to qualified care, we're not going to provide it, nor will there be a societal outcry to provide it. Hence why today, and I appreciate everybody being here, because that to me tells me that there are people, everyone on the Zoom included, that see the dearth of access, see the dearth of the ability to have qualified individuals treating our patients. And so we have basically a call to action of what we can do to help our entire society versus just select strata of our society. So some implications for clinicians, and I'm trying to keep to time. Recognizing poverty, intergenerational trauma, how that affects an individual, how that affects a family, how that affects children, and what are those reactions to trauma? What does that trauma response look like, right? And I found a comment said, as I have been a sub counselor for many years and working with the homeless, I must say that I've learned that substances do not care what color or race you are. Substances don't. Substances are equal opportunity destroyers, destroyers of communities, destroyers of families. And we do, and I'm going to assert this, we do need to get away from this moral model and more into how can a public health model, a biopsychosocial model, and look at what is causing this, right? Intergenerational trauma. I do have a recommendation for a film. I'm a big fan of PBS. I'm going to plug PBS. It is called The Last Generation, and it talks about intergenerational trauma of survivors from the Holocaust. Another one is PBS, and it's called Poor Children, and it talks about intergenerational poverty from the child's perspective. The other part of our implication is understanding our implicit bias. So I'm going to ask for some vulnerability from y'all. How many folks, when I showed you the pictures of the different groups, low SES, middle SES, high SES, some biases came up for you. Some wording came up from you for you in your head. When we talked about the different types of drugs, you had an image of what that person looked like. Well, I'm going to raise my hand because we all have biases, okay? How many of y'all were kind of shocked and were like, man, I hope he doesn't ask us to raise our hand? Most of us, because it's a hard conversation to have with ourselves. It's a hard conversation to acknowledge where we are in that growth process, where our understanding of ourselves lie. And that's the first part of this conversation, right? I'll share a little bit with you anecdotally. I worked at a contract with an agency, and it was in the Denver metro area. And we have some sports teams there. I'm not sure if you're familiar with them. I'm not a sports fan, but a lot of people are pretty into those teams. And we dealt mostly with domestic violence, and we dealt and substance use disorders. So folks that were on probation, parole for DUIs, substance use, domestic violence. We had two entrances. We had one entrance for the regular folks, and then we had another entrance for guess who? It's okay. Guess. It's not fatal to guess. Well, in some circumstances. The rich, yes, thank you. It was, yeah. There were folks that were not going to come into the front door because they could not be seen going into an agency. They were going through an alternate entrance because they couldn't be seen for whatever. And I remember looking at my client's face when somebody would come in, and they would see, oh my gosh, I have to be, and I heard this more than once, I have to do group with these people. And from a therapist, that broke my heart, because I have, and I'll go back to our slides, stood at the front desk where I had somebody on a client on the phone calling somebody, asking them to sell personal possessions in order to pay the $5 copay for a urinalysis. So it's a stark contrast when you're looking at this, within the same agency, of having that. And my thing just went crazy. Sorry. Go. Having that experience as a clinician really opened my eyes up to the differences between folks, and how we as providers view those individuals. Other implications is we can operate in silo, as we've been doing, where we treat mental health and substance use disorder, and where we take disadvantaged folks and we really compartmentalize them. Or we can operate systemically and create a continuum of care where healthcare and mental health and substance use disorders are coalesced, and we're screening for all of them and treating all of them in a continuum of care, and allowing ourselves to open our practices and our community centers, healthcare centers and mental health centers, to all strata of patients and clients, consumers, however you'd like to term it, in order to treat them as needed. And that goes to a barrier of care, and I'm going to hop on that really quick, is when we don't have facilities in every neighborhood, we don't have therapists in every neighborhood, a part of the city, that creates a barrier. That creates a very real barrier to treatment. Other parts, understanding our own family of origin concerns, what our biases are. Regardless of your family of origin, once you obtain a baccalaureate degree, a master's degree, a doctorate degree, you generally will move up or differentiate from your family of origin unless you're remaining in the same strata. And understanding what those biases are. Are you constantly looking upward bias to generational folks with high SES as being more knowledgeable and more deserving? Are you looking down? And this does happen where individuals will look down on their family of origin, their SES of origin, as undeserving because the reference group, they want to stay up here. And so they create a new way of being and thinking, and any contact with their original family of origin, their socioeconomic status, becomes a danger. And that really creates a bias as well, because think about this to yourselves. How many folks who provide treatment go, I don't want to deal with, and I'll just let it sit there in the room, right? Whether it's Medicaid, poor people, those people. That's why we see deserts in lower socioeconomic status communities of therapists, of substance use providers, because the mentality of I don't want to. Does that make sense? Any questions or things? Like I said, I just use this to keep a kind of framework where I want to go, but trauma, there was comments that found trauma seems to be the cornerstone that builds the future of COD. And trauma is the cornerstone. That is one of the things that we do as academics, as practitioners. We do recognize, and we do a poor job of treating trauma in our society. We generally treat trauma when it becomes too much for this. And I say too much, air quotes around that, for society. Other than that, we just kind of take a step back. When you look at how long it took us to get a diagnosis of trauma just into the DSM, it tells you how much we avoid it and all of the comorbidity that does come with trauma. Oh, a little more of the implicit bias parts. Think about how comfortable you are sharing any of this with anybody. And then ask yourself, what does each one of these questions, and you don't have to read all of them, what does any one of these questions tell me about myself and tell me about my clients, my patients? What are your preconceived notions? So I'm going to use the local grocery store chain around here. We need to see some faces. So you can take your hands, if you have a camera on, and go high end all the way down to low end. Nugget. Whole Foods. Rayleigh's. Bel Air. Smart and Final. It's up to you. I'm not making the judgment. So you get to, it's your biases. But that's the point. So, and the reason I bring that up is because when our patients come to us and they start talking, as soon as they open their mouth, we start assessing before we even see anything about their ability to pay, because that's usually helped at taken care of at the front desk. We look at their clothing, and we pay attention to their verbalizations. About 30 seconds is what it takes for you to make an assumption about the person sitting in front of you. Whether that's how they speak, how they dress, how they look, we start making assumptions about them. And so just a grocery store, right? It tells you where you live, what it looks like, what kind of car you drive, right? I'll share an anecdotal story with you. I came from Colorado Springs, and the United States Air Force Academy is in Colorado Springs. And I taught at the University of Colorado Springs in the graduate counseling program, and we had AOCs, Air Force Officer Commanding, come over from USAFA, and I taught them. And one of the things that they often talk about were ring knockers. Anybody know what a ring knocker is? Ring knocker, I apologize, my phone's buzzing. A ring knocker is somebody who went to the academy, whether it's West Point, Annapolis, Air Force Academy, because they get a giant graduation ring. And the non-ring knocker Air Force officers, these are Air Force officers, field grade Air Force officers, lieutenant colonel promotable, usually once they finish their tenure at USAFA, their 2-3 year commitment at USAFA. And, they would talk about this disparity oftentimes in meetings because the academy grads would hang out together. There was this feeling of, because most of the folks who went to state school, they had varying backgrounds, but just in that experience alone, just that ring set aside of what my place in the world is. Any thoughts or questions? I see some comments popping up in the chat. Okay. So let's talk about our implicit bias pathway. So as a provider, as a mental health professional, substance use professional, you have your implicit bias. We've talked about that. And that impacts our judgment. So do we water that bias, ignore, and by watering it, that's also ignoring it, to allow it to impact us, which creates a disparity in health? Or do we acknowledge it and communicate and trust our patients and engage with them in order to avoid this disparity in health? And the reason I left the arrow here is because this can break down at any point. If we stop engaging with our clients and understanding that their intergenerational trauma, their intergenerational poverty, living in unsafe environments, all can contribute to their current mental health or substance use diagnosis, then we start to create a disparity in health and access to health. If we ourselves are not willing as providers to go into communities, underserved communities, to work with clients, we ourselves are contributing to the disparity in health. If we do not acknowledge the necessity of treating both mental health and substance use disorders concurrently, we ourselves are creating disparities in health. And so I would like you to think to yourself of how you can contribute to the engagement and communication and trust with our clients versus continuing our road on these health disparities. So the access to healthcare, make sure that anybody seeking services has access to quality healthcare, and I'm including SUD, mental health, and medical in one frame. Make sure that we are providing education to communities. Make sure that we have hospitalization available for those that need inpatient care, and not just 28 days. We know that it takes 90 days plus for treatment. If you just do 28 days and send people back into the world, they're going to relapse. Make sure that we have outpatient facilities available to them. Make sure that we are all on the same page of mental health and treatment outcomes. Make sure that we legislate for Medicaid expansion. And when I talk about treatment, I joke. I use CBT. I'm an existentialist. That's my theoretical orientation. But I tell my theories class, I joke. I say I love pure CBT therapists because after 4 sessions, I've got a new client. They keep me in business, right? So we need to make sure we have long-term, not just brief, that we are providing long-term mental health services, and solution focus and CBT are fantastic working with SUD, that we are adequately training our graduate students and our medical students to identify trauma, identify mental health and substance use disorders. Structures needed for support in the community. Children, make sure that children have access to basic needs, that we're assessing for ACE at every turn. Make sure that schools have trauma-informed curricula. Make sure schools are able to promote pro-social behaviors. Make sure that families have resources. Make sure that, and I'll go to here, make sure that our medical offices have, and I'll use this one, assess for ACE, and in adults, assess for trauma. Understand the difference between acting out in schools and what is trauma or mental health. Also look at adults and understand what a trauma reaction is versus a non-trauma reaction. Now, and to ensure that individuals have resources necessary. And those resources are also your resources that you need as a healthcare provider to treat your patients. And this is something, and I'll kind of climb off my little soapbox here in a second. And here's some resources for you all. And if you want, I'll actually give this to Dr. Rivas, and she can put it up for resources. Working with our clients to understand, and I'm going to go back to communities of color and low SES communities in general, that we often neglect to pay attention to living in poverty is traumatic in of itself. Oftentimes, police interactions are not the friendliest, right? Think of your own interactions with police. Do they differ than your patients or your clients? Do you live in an environment where you feel safe with police interaction? Do you feel safe walking late at night in your neighborhood? Those all contribute to just living trauma. And that's something, and I want to put it out there for you to think about, is assessing for that. Because going back to, we know that that's a genesis for substance use disorder, and not looking at substance use disorders as a moral failing, but establishing an evidence-based approach to substance use disorder, which does inherently public health model, medical model, and a biopsychosocial model can all encompass that and provide the opportunity for us to treat our patients in a caring and professional manner. About 5 minutes. That's my 45-minute elevator speech. Are there any questions, comments? Tell me to go to hell, anything? Give you permission? No? I'm seeing smiles. Maybe somebody wanted to, but what are your thoughts? What are your thoughts on this? Don't be shy. Joe?
Yeah, the thing that struck me the most was when you were putting up the different drugs, and immediately, my mind went to a certain demographic, a certain ethnicity, and someone made the comment, and I was taken aback by that. I was like, wait a minute, I something I got to work on. So, that was pretty shocking. And then also, I was a teacher for 22 years, and we see these types of things with kids from all social classes and families as well. It affects everyone equally. I taught in Title I schools, and I ended my career at a private school here in Sacramento, and I saw the same things with substance abuse with the families. So it definitely does not discriminate.
Not at all, right? Just changes zip codes. And so there was a comment, the first picture took to certain stereotypes, right? And think about that with that, piggyback on that is, if you've ever had a patient or a client sit, they walk in and you look at them and you go, oh, here we go, frequent flyer. Oh, this person's not gonna comply with treatment, right? It's that blip. Yeah, and there was a comment surprised me because since I'm Latina, about certain stereotypes, we all have biases, regardless. Biases don't disappear. Every human being, and as I say, if you have a pulse, you have biases. You do, and just it's always paying attention and understanding what your biases are, right? So, Joe, I'm going to pick your schools, right? It's a private school, so everything must be cool. No, just different zip code, same stuff. Seth?
Yeah, I was just flashing back to the example you gave about I think it was a stadium with separate entrances for various people of different socioeconomic backgrounds. And I grew up in a very poor community that didn't have a high school. It was a rural area. And so we all got shipped into, it was in the Tucson area, so got shipped into Tucson for high school. And I just remember that for the most part, those of us who came from the 3 Points, the name of the place, but we never really, or at least it took a very long time for many of us to mesh into that, to the rest of the school, which was still a low income school as well, but wealthier than where we came from. So my thought, that's a long story, just to say that all these things start so early in the lives of, for all of us. So, and then also you can wrap all kinds of racial inequities into that as well, that I could go on and on, but it just, the main thought there is just that it starts so early in our lives.
The messaging very, very early. And the messaging of how those people, air quotes, because in the recording, those people think and what they do, right? I'm new to Sacramento, but in the last session, it's South Sac, right? I've heard South Sac so many times, and it's like, what's the connotation, right? Like, it's a neighborhood. It's a neighborhood, but where are all the nice therapists' office at? Midtown, right? And then the burbs, yeah, it's the messaging starts real early. Other thoughts on this, or how you yourself can help break down that disparity?
I think for me, I've lived in a handful of different places, but grew up in Los Angeles, which again has a million different neighborhoods and components to it. But I think all the pictures that you showed were very good reminders to myself that was almost like good grounding. But like, oh yeah, there is this much diversity, and there's more than even what was in your pictures. And just remembering that each one of those people in each picture is a human being, and to treat them as an individual that comes with what they come with. And then also remembering that we all grow up in an environment, whatever the environment is, and that's what's familiar, and that's what we learn, like Seth said, from an early childhood. And so keeping that in mind, that is where a lot of this stems from, and just being aware of that, and then being open to what else is out there, I think is a really good place to be, especially working from a therapeutic, mindset.
That therapeutic framework is, that we're all in this together, right? And to treat everyone with the same amount, because I think the overarching is substances don't discriminate, right? And when I say methamphetamine, I can pretty much guarantee my powers of prognostication are, I know what socioeconomic status you're going to say, right? But I've seen people with 6-figure plus jobs because methamphetamine does the trick. I've seen, the substances, don't discriminate, right? Other thoughts, comments, concerns, hopes, fears, dreams? I got a lot of hopes. I got a lot of fears, but I got a lot of hopes. And I think my hope is, and I'll be a Pollyanna on this one, that the fact that you all showed up to this particular discussion about socioeconomic status, bias, and how it affects treatment, and on monitoring our own implicit biases, gives me hope that we'll see more access to care, more quality care, more legislation that comes from a public health, medical, biopsychosocial model versus a moral model, which still systemically disenfranchises communities of color and low SES communities. and we can make changes where we can have more resources. And I know the folks that probably work in publicly funded agencies, do more with less is the mantra. And it's like, no, we shouldn't have to have a bake sale to treat people, right? We shouldn't have to do more with less, or go, okay, you're on a 6-month waiting list to get in because we can't afford the space or we don't have the staff to treat you. That as a society, we can say, you've expressed a need for substance use, mental health concerns, treatment, medical treatment. Let's get you in and let's get you situated. What the person does with that after the end, that's up to them, right? We don't pull them across the finish line. But that's my hope. That's what I'd leave you with today. Okay, I think I went over. I apologize. You'll have access to the recording, and I hope you all found this worthwhile. If not, I apologize, but I think it's worthwhile. All right. Have a fantastic rest of your day, and I will let you go.